If you're a driven, active person who wants to reach and pursue a higher quality life with some ambition, then guess what? This podcast is for you. This is the Driven Athlete Podcast. What's up, y'all? Welcome back to the Driven Athlete Podcast. I have got a lot of questions about muscle trigger points, all right, and muscle tightness. So this is extremely common, of course, and I'm always going to be an advocate for soft tissue work. From our end, when somebody has muscle tightness that's been kind of going on for a little while, it's like, I don't know what I did or why. That's our bread and butter. All right. Imaging is not going to be remarkable. Typically, imaging won't be remarkable for this, where it's like, I think I pulled something or something's tight. I have trigger points on my neck or my trap. Should I get an X-ray, MRI, like whatever? Non-traumatic pain that develops like this, especially like muscle pain, it's not going to, imaging isn't going to change what we're going to do. The rationale for imaging in that situation is to rule out underlying problems that maybe we're missing. All right. And that we call those red flags. All right. And we can be 98% confident that somebody doesn't have a red flag present with just screening questions. All right. So let's say hypothetically we've ruled that out. Red flags, we're 98% confident it's not a red flag. This person just has trap tightness or trigger point in their shoulder or in their low back they just noticed it, and they exercise a lot. They feel it more when they exercise or after when they exercise. So it's non-traumatic. They didn't like have a car accident. They didn't fall down a flight of stairs. They didn't have like a barbell fall on their face or something like that or on their back. How does that happen? Well, that non-traumatic pain is sounding the alarms, which is the muscle tissue usually, because something else is going on. And we have to investigate what caused the pain in the first place. All right. Like, what's the cause of the cause? The cause of the pain is that muscle tightness. All right. And that trigger point or whatever in your trap. But that's not like the cause of the cause. If we don't identify the cause of the cause, it's just going to keep recurring. All right. And that's what we have. That's what we find a lot from people who only get soft tissue work or just passive stretching. So it's not going to solve tendonitis. It's not going to solve underlying trigger points. It's not going to solve chronic tightness in the muscle tissue. And here's what I'm going to explain. All right. We have to figure out and investigate with an accurate diagnosis what the cause of the cause is. And I think that comes from approaching it with the right lens of how these issues come about in the first place. All right. And that's going to dictate our diagnosis. So like, what's the problem, which is going to dictate how we treat it. And if people aren't getting better, or it's not solving 100%, like not resolving completely, that means our diagnosis probably wasn't accurate, which is our school of thinking and school of thought and our underlying perspective on the lens and how we're going to approach this anyway, which is tricky. All right. This is my opinion. All right. This is all this, like I've had really good results with people with stuff like this all the time. And here's what I'm going to convey. So things don't hurt for no reason. All right. Things don't just start hurting for no reason. There's a reason why. And usually it's from underlying movement pattern compensations that are making this particular muscle get guarded and jacked up and trigger points develop or tightness. The muscle, of course, is being overused and it's overcompensating. But why? Right? Muscles don't just get overused for no reason. So things don't hurt for no reason. Something's usually going on beyond the muscle joint, the muscle in this joint. We have to investigate the joint that muscle connects to, the joints above and below, as it relates to the movement that caused the symptoms. So let's say somebody has like upper trap pain with shoulder press or something. All right. Like they push their ball overhead or they push dumbbells in chest press or something, or incline bench. We're going to investigate the scapula. All right. It's a shoulder-based movement. We have to investigate the scapula. We have to investigate their shoulder stability and the shoulder joint itself. And then also their neck. All right. We have to rule out their neck. All right. And part of the neck is their first rib, their upper rib, their first and second rib. So those are the things that we're considering. All right. Why is this trap getting tight and trigger points develop in the first place? It's got to be something, and it provoked more with these movements like bench press or military press or something, or even barbell squats, or farmer's carry. That's a common thing. All right. So we have to investigate the surrounding joints that these muscles connect to. All right. But anyway, so the upper trap is getting overwhelmed. It's overcompensating in some capacity. It's protecting, it's overcompensating, and it's getting overwhelmed. And that's why it's getting broken down and tight and guarded all the time. So we have to investigate the joint limitations above, around the area that they connect to. All right. So if we don't investigate that, it's just going to keep recurring. And that's where just soft tissue work by itself and stretching by itself doesn't actually solve the problem. It just keeps coming back or just doesn't go away. All right. Just when it gets stronger, let's say the trap as an example, the upper trap and the shoulder and the neck. Very commonly, people will have pain that goes further down the trap, either down their shoulder blade, like behind their shoulder blade, or down their arm. And that our first hypothesis with somebody coming with pain like that is that it's referred pain from the neck. All right. It's referred cervical pain, neural irritation, and the nerves are just sending signals. All right. So we're definitely going to investigate the neck, and the first and second rib are also key players with potentially causing upper trap tightness and pain and referred pain as well. And then the other things we have to investigate is it coming from the shoulder, the shoulder blade, the scapula, or the shoulder joint for the internal stability of the shoulder joint itself. So those are the things we're going to investigate. So if somebody has referred pain like that, we're going to watch them do the movement. Like, show me, what's it look like, right? We're going to check out their range of motion. So let me see your shoulder range of motion. Let me see your scapula. We're going to see its positioning. We're going to look at their neck range of motion and mobility, where they're compensating, what their quality of movement looks like. And then we're going to look at for the functional movement that causes the symptoms. Like, make it hurt right now. Let me see you do the bench press, or like, let's watch you do shoulder press, or let's see you do this. And we're like, oh, well, like, here's some compensation patterns we're noticing when you're doing this, strengthening this hypothesis versus strengthening this hypothesis of like what the problem is, right? And oftentimes with that, people will hyperextend their neck when they do shoulder press, bench press, farmer's carry, deadlifts as well, kettlebell swings. Those are common things that people will hyperextend their neck, as like they'll bend their neck backwards as they do those movements with not in a stable position. And that's making the joints in their neck get irritated. And the muscles that connect there are guarded. And then the nerves that pass through those areas from the facet joints and the cervical spine down the chain, they're going to send signals. They're going to be like, that's the fire alarm going off. All right. So if we only just treat the upper trap with dry needling or cupping or massage, soft tissue work, the upper trap and the referred nerve pain is like a fire alarm going off. Like something's wrong. All right. That if we only treated it like that with soft tissue work, that would be like if we shoved a pillow against the fire alarm to muffle the sound and make it less loud, all right, less aggressive. Like, oh, now the fire alarm isn't going up as much. But meanwhile, the fire in the corner is still actually burning. We didn't actually stop the fire. All right, so at some point, the chickens are going to home to roost and the fire's going to grow, and then not all the muffling in the world of the sound of the alarm isn't going to help, which would be like meds and injections. It's just going to have to keep adding more. We got to muffle the sound even more. We got to muffle and dampen this fire alarm noise more and more and more, but not actually putting out the fire. So what we're suggesting is, and then the lens in which we perceive this, let's just put out the fire. All right. We're going to help the fire alarm settle down too, for sure. But only doing soft tissue work isn't actually putting out the actual fire of why this issue started in the first place, which is commonly a complex combination of joint compensation, movement pattern compensation that's leading to the upper trap or the neck muscles to have to protect and overcompensate. Needling isn't going to solve that. If it's hyperextension in the neck joints, the scapula isn't as stable or moving as well overhead as it could, moving as best as it could. If the shoulder joint isn't as stable as it can be, it's setting up the trap for failure. And it's also making the neck have to hyperextend and overcompensate, just a compensation movement pattern. So we have to fix those compensation patterns, right? Manual therapy sets it up for success so it can move better. And then the corrective exercises that we prescribe solidify those changes and activate and recruit the muscles needed, and then reinforce the improved movement mechanics, all right, the movement patterns. And that harnessed and honed in on and repetitively worked on over many weeks is how it actually solves the problem. So that like a year from now, somebody's able to do shoulder press, bench press, barbell squats, kettlebell swings, or deadlifts or something like that, and not have the pain recur. And something that we mentor our doctors of physical therapy that come work with us for mentorship is we ask them, let's say you work with them and they're feeling better and you say, all right, cool, man, you're good. Go work out. 3 months later, they call us back and they say the pain came back. That means you didn't solve the problem. And that's just a classic indication that's like we're not actually diving into the issue. And it's a diagnostic problem. It's a treatment course of action problem. And it's also, I think, even beyond that, the underlying foundation, it's a lens of how to perceive these issues problem. That's got to be fixed. It's a perspective on how this having to start in the first place. That's going to dictate how you diagnose it and what you think the perceived the problem is. And that's going to dictate how you try to treat it. And it doesn't get better, then something's wrong. And all those things have to be considered. Anyway, that's what we work with the doctors of PT, the doctors of physical therapy that come mentor with us for high level clinical training. That's the thing we investigate and ask them and grill them on. We're like, yo, if we don't get better, and then you tell them to go back to their sport or activity 100% and it comes back, then you didn't solve the problem. It's just usually a diagnostic problem, underlying from a foundational lens problem, in my opinion. Okay, so we have to fix the underlying movement pattern dysfunction. And in this example, for the upper trap in the neck, or levator scap, or medial scapular problem, referred pain, or even down the arm, it could be a shoulder problem for sure. It could also be a neck problem. And we have to intervene and improve the mobility of the hypomobile joints, the positioning potentially too of those joints as like where they start in the movement. If they start stuck in the mud or if they start hyperextended, like we have to fix that movement pattern. And then mobilize the other joints that maybe aren't moving as well too. We can settle down the pain from the hypermobile joints with just leveraging neural acclimation and getting nerves to settle down, the neural irritation and sensitivity, and that's going to help with muscle guarding. And then, of course, we're going to do soft tissue work. We're going to work on the restrictive tissue, though. We're going to work on the restrictive tissue that's causing limitations of mobility. And oftentimes, the muscles that are having trigger points or tight and guarded, they're not the problem. They're the victim. They're overworking. So if they're overworking, and they're trying to hang on for dear life or activate as much as they can, would crushing them with soft tissue work and crushing them with needles, would that actually help the situation? The argument would be probably maybe not yet. All right. They're overwhelmed. They need rest is what they need. They need a break from what they're doing so much, where aggressive soft tissue work is just going to irritate them more, right? They're already irritated and overwhelmed and sensitive and hypervigilant and hyper irritated. So that's not going to be advantageous right now and indicated right now. But other soft tissue that are key players in this complex situation of movement mechanics, those muscles, we need to improve the extensibility and the pliability of those restrictive muscle tissues for sure. And then later we can maybe work on more of the soft tissue that's really irritable. So a classic thing that we work on all that stuff, and a classic occurrence that happens is we won't even touch their upper trap. We won't even do upper trap work because, in my opinion, it's overwhelmed and it's overworked. But we'll work on other things: the upper cervical mobility, lower cervical mobility, first rib mobility, usually the scapula mobilizations, it's activation of scapular musculature, activation of the deep cervical stabilizers, and then postural movement control and coordination and dynamic stability movement patterns, or fixing movement patterns. And then on the way out, we'll say, hey, let's do your movement again. Remember when you first came in and this exercise, this movement caused the pain? Let's try it again. Let's retest. And then it'll feel better. They're like, I feel way better. Like, what did you guys do? That feels a lot better. And we didn't even touch the trap, the upper trap that was the main complaint when they first came in. So the bottom line is, if we fix the underlying problem in the joint mobility issues and the restrictive tissue, that's usually not the other one, the actual trigger point area, if we fix the underlying joint and their mobility and the movement patterns, the soft tissue will follow suit. The soft tissue will settle down. It'll melt. It'll function way better because it's set up for success now. And that seems to be a common occurrence that happens with our patients. We're like, hey, this is encouraging. You feel better. And we didn't even touch your trap. We didn't even touch it and it feels better already, right? That's because the trap isn't the problem. It's overwhelmed and it's irritable because it's hanging on for dear life and it's trying to do too much. So that's a common thing. A great example of this too is if the hamstrings are tight. All right, so if somebody has a tight, man, if I had it's very common occurrence, people think their hamstrings are tight, which is understandable. It feels like that, and they've probably been told by other clinicians that they're tight hamstrings. I'm very confident for a lot of people, almost everybody, like a ton of people we've worked with, that they come in and say that my hamstrings are tight. The hamstrings feel tight, but they're not the problem, and your hamstrings aren't pathologically tight. Like they're not like tight to a problem where like we definitely need to stretch. Like if you want to fix your problem, you got to stretch your hamstrings. There's never been a time I say that, unless I take that back. I have said that, but nothing for this. All right, there's been a different situation, but very rarely are we like advocating someone to stretch their hamstrings to solve their problem. It's not going to solve the problem, and their hamstrings really aren't tight. They're just guarded right now because they're set up for failure because they're overwhelmed, they're irritated, and they're hanging on for dear life, and they're being way overactivated. All right, their hamstrings are dominant. So we're not going to strip and dry needle and crush soft tissue in your hamstrings because they're not the problem. All right. In these situations I'm describing, all right, it could be referred pain from the low back and the lumbar spine. It could be a length, all right, hang up, bear with me. It could be a length tension relationship problem from where the hamstrings insert from the pelvis to the knee joint. All right. So that would be like a SI joint instability dysfunction. All right. So the sacroiliac joint, the SI joint, can be dysfunctional and asymmetrical and at what we would call like a biomechanical fault. And if it's influenced if one side of the pelvis is influenced one way versus the other, the hamstrings can be chronically over lengthened, making them feel like they're tight. Where soft tissue work, stripping, cupping, soft tissue work, dry needling, whatever, it's not going to solve that. It's just going to make the hamstrings are already irritated. It's just going to make them more irritated. It's not going to solve the problem. But if we fix the SI joint, all right, and then improve some of the neural referred symptoms, create a little bit more hip stability, glute recruitment, and dynamic and knee, and that recipe, we don't even touch the hamstrings. This is day one. All right, we do this, and they leave and they say, my hamstring feels better. I'm able to reach down further. I'm able to squat better. And like, I don't even feel my hamstring. It's like, we didn't even touch your hamstring and it already feels better. It's because the hamstring wasn't the problem. It was set up for failure and it was hanging on for dear life. And it might've been just recently chronically over lengthened where stretching your hamstring, it would make it worse. That's not the problem. All right. Would you want to stretch something that's already at its full length? It's like, it's already stretched. You want to stretch it more? It's not the problem. Also similar conversation with the IT band. All right. The IT band isn't tight. All right. Relax. It's not tight. It's just overwhelmed and it's chronically over lengthened usually from a hip instability issue and maybe even a pelvic stability issue, which is core stability, glute recruitment, hip mobility, and then just like dynamic movement patterns. All right. It's dynamically stable movement patterns. And it's setting up the IT band to hang on for dear life. And that's the tissue that's overwhelmed and overstressed. So would it make sense to crush soft tissue on the IT band if that's what the setup is? It would not. Would it make sense to stretch the IT band, which it really doesn't stretch, by the way? It's a thick fibrous fibrous tissue that doesn't really stretch. Would it make sense to try to stretch it when it's over lengthened and overwhelmed and chronically trying to hang on for dear life? It's overly stretched chronically. Would you want to stretch it more? It's not going to help. It's going to make it more irritable. And that's why people come see us, because things aren't getting better. Then we have conversations like this and they're like, oh, this makes a lot of sense. Thank you for explaining this. I'm glad I feel better right now. What did you guys do? Like, perfect. Here's the plan. Here's the course of action. We got to continue this course. You're feeling better right now. It's super encouraging. And we didn't even touch your IT band. We didn't even touch your hamstring. We didn't even touch your upper trap or your levator. It's going to follow suit when we fix the proximal stability or biomechanical faults, joint mobility, movement patterns, all that recipe we're talking about. That's encouraging, right? We didn't even touch it. So cool. I'm very confident you're going to get better. We just got to continue the right path. So that's a common conversation we have. And those are my thoughts on muscle tightness and muscle trigger points. They're not the problem. They're overwhelmed. They're set up for failure. They're chronically being overly recruited. They're very tight and tense to protect. They're in protection mode. And we got to set up it up for success. And doing soft tissue work on them right now isn't really going to help that. It might be making more irritable. So if you ever see a clinician or a practitioner that's working directly on the tissue that's like really irritable and sensitive, I would ask them, why. Like, where's your head at? What's your thoughts on this? Just want to maybe see what their argument is, But anyway, I'm always open to conflict, conversations, and differing opinions, comments, questions, concerns, conflicting opinions. Like, I'm always open to these conversations. And if you have any questions about pain, if you're battling any issues right now, don't hesitate to call us, because we'd love to have a conversation about what you have going on and maybe how we can help, at least point you in a different direction, and where to go or what to expect. And the best way to reach us is our phone number, by the way. So 561-899-8725. Give us a call. It's the best way to reach us. Like I said, we just at least talk on the phone, see what you have going on, and maybe what direction to point you. So hang on to that. Send us to somebody if you feel like it'd be valuable for them, and we'll catch y'all next time.